All right, this is the fourth in the immune system, blood typing, clotting emergencies. I want to talk about the A, B, and ABO and RH antigens, and also just a few clotting emergencies. We're getting the very near end of talking about blood and immune system, and all of this blood typing ties into it. First question, what does define an antigen? Is it a pathogen like a virus or bacteria? Or is it something that is foreign to oneself? Something your body has never seen before? The answer is, it's something foreign to oneself. So antigens are not always a pathogen, it's just different. Typically, it's a protein or polysaccharide. It's present on the surface of the red blood cells. And so I put these three on the surface of red blood cells. The blue ones are antigens for blood type A. I've put the purple arrows as antigens on the surface of people with B blood type. And then the other antigen is this, I put as a green diamond for RH antigens. So remember the allergy rule. You can't be allergic to something your body's never seen before. For instance, you can't be allergic to penicillin or bee stings if you've never had penicillin or been stung by a bee. So what is it about blood transfusions? If you've never received a blood transfusion and you're a type A, why are you allergic to someone with type B? Okay, so that's the next question. Why do people have antibodies against A and B when they have not had previous blood exposure or transfusion? Is it genetically coded on the DNA that you're going to have these antibodies? Or is it acquired through life exposures? And the answer is it's acquired through life exposures. The production of antibodies are produced through life exposures. So your A, B, and O and RH are genetically coded, but the antibodies themselves are not. So up to 6 months, babies are exposed to bacteria or viruses, and these antigens, the viruses or bacteria, are similar enough to A and B antigens that they develop antibodies. So if they have type A blood, they will have antibodies against type B blood. So type A blood has antigen A on their surface, and so they develop antibodies against B. And then for people with type B, they have antibodies against type A. Type AB, because they have both, they produce no antibodies to A or B, and so they become a universal recipient. They can receive anybody's blood. Type O blood has no antigens on the surface, and so they have antibodies against A and B blood. So they're the universal donor. Oh, this is how I remember the ABO blood typing. Think of it as, this is my depiction of the antigen kingdom. Now, it's the castle, you've got the castle, and within the castle is type O, the O queen. And I put it like this because I'm a type O. It makes sense that I'm the queen of the castle. And in the neighborhoods, you've got 3 neighborhoods. In one house is type A, type B, and then type AB. So here's the antigen kingdom. Again, I'm Queen O. People in the neighborhood of A have antibodies that they've developed against B. And B, since they're socially isolated, as well as A, they're tribal, they've produced antibodies against A. And AB are pretty much anybody's welcome. They haven't developed antibodies against anybody. So this is my antigen kingdom. Queen O, she's a universal donor. She can go anywhere, but nobody can come into the castle unless you're another O. Type A and B, they're feuding houses. They only accept Queen O because they have to, and they only accept one of their own kind. And AB is the duck. They are the universal recipient. They welcome anyone. So let's go to another medical scenario. A woman is type A. She carries antibodies to type B blood. She gets pregnant. The father is type B, is type B. Okay, so the question is, what happens if the fetus is type B and the mother is type A? Is it the mother's antibodies will attack the baby's blood in utero? Will the baby's antibodies kill the mother or attack the mother's blood in utero? Or nothing will happen if the placenta is intact? Now remember, the baby hasn't been exposed to any bacteria or viruses. So first of all, the baby has no antibodies that have been developed in utero. But the answer to this is nothing's going to happen because the placenta, if it's kept intact, nothing's going to happen during the pregnancy. So the antibodies to type A and B are just too big to cross the placenta. They're immunoglobulins that are too large, so they don't cross the barrier. But we have to be careful because there's one more antigen on the red blood cell, and it's Rh, and it is another protein that can be present on red blood cells. And these Rh antibodies, the immunoglobulins, are much smaller, and they can cross the placental barrier. So now we've got 3 proteins. These are the most common proteins. There are many more proteins on the surface of the red blood cell, but the people may not have antibodies to them if they have not been exposed to lots of blood transfusions. That's why it's so difficult to transfuse someone who's had lots and lots of different blood transfusions, because they start developing antibodies against different antigens. All right, so, and all of these, of course, are genetic. These antigens are genetic. The antibodies are not. The Rh genetics is a dominant pattern, and so that it means that if you have an Rh negative mother who has no genetic predisposition or genetic coding for Rh, and she's paired with a father who has just one copy on his DNA, half the children are likely to be positive, Rh positive, because it's a dominant gene. Well, this is a medical scenario. An Rh negative woman is pregnant for her very first time. The father is Rh positive, and the baby inherits the Rh positive gene. Question: will the mother develop antibodies against the baby's red blood cells before the baby is born? Now, this is the first pregnancy with this baby. And the answer is no, yes, or not unless there is a break in the placental barrier. The answer is she's not going to be developing antibodies to a baby unless there's a break. All right, so remember, red blood cells can't cross the placental barrier. So if they can't cross, then she can't be exposed to it. The problem is up until, well, about the 28 weeks, you can have these micro tears. So there's a potential of blood getting to the mother and her developing antibodies. Also during the delivery process, for sure, she gets exposed to the baby's red blood cells. And it's not a problem for that first pregnancy, but it is a problem for subsequent pregnancies. So the first pregnancy, you've got an Rh negative mother, an Rh positive fetus. During the delivery, the mother gets exposed, and then she starts to develop Rh antibodies. So what this means is for a second pregnancy, that's the most concerning, is subsequent pregnancies after she's had an Rh positive fetus. These Rh antibodies, remember, they're very small. The immunoglobulins are very small, and they can cross the placenta, and they can attack the fetus's red blood cells, and the baby will die in utero. So here's a medical scenario. And by the way, we're going to talk about prevention of this happening in a couple of slides. So your medical scenario is a 24-year-old cousin who spent, female by the way, spent several months traveling abroad following graduation. She tells you that she has not had a period in several weeks. Name a couple of important medical tests that she would need. Now we're going to make the assumption that she's pretty goes fast and loose. How about I use that? Okay, so medical tests you want to know about in her HIV status. Perhaps she's been exposed and may need to be on medications for HIV. Need to know her pregnancy test. Other sexually transmitted diseases. So if she is pregnant, you'd want to know if there's a risk to the fetus from a STD. And then if she's pregnant, you want to know her blood type, and want to know if she's Rh positive or Rh negative. Now, if she's Rh positive, it doesn't matter. It only matters if she's Rh negative. So now we go on. So she's 28 weeks pregnant. Her blood type is A, and she is Rh negative. We don't know who the father is. So we don't know what blood type he is. So at this point in her pregnancy, how could you prevent her from developing Rh antibodies for this or future pregnancies? And the answer is Rogam. It's a shot that's given to the mother. And the Rogam gets into her bloodstream and kills all fetal red blood cells in the mother's blood before her own immune system can develop Rh antibodies. So at 28 weeks, the risk of placental breaks begin. So this is the time when, if a mother hasn't had any bleeding or problems, to make sure she gets Rogam, so she does not develop antibodies. Okay, so this is an infographics for Rogam, showing how it destroys the fetal red blood cells. So the mother's immune system doesn't have time to see the cells. She doesn't create antibodies. So this is another plug for why it is so important to have prenatal care early on during pregnancy. All right, let's segue to another topic. I want to just make a brief talk about clotting emergencies. The clotting system is vast, and we're just going to go into just one aspect of it. And we're going to start with the case presentation. This is a true story. David Bloom was a Desert Storm reporter. This is a 38-year-old journalist, and he was riding on the back of a military vehicle through the desert. After about 3 days, he starts getting leg cramps, shortness of breath. Then he has complete cardiovascular collapse and he dies. So the question, riding for hours each day in the hot sun, he developed acute shortness of breath and cardiovascular collapse. What killed him? Did he have a heart attack, a pulmonary embolus, or leg cramps from dehydration? And the answer is he ended up having a pulmonary embolus. Now, being in the back of the truck and being in that cramped position predisposed him probably from some dehydration that made his, that decreased his blood concentration. So he was more at risk for that as well, for blood clot to develop. So this is a plug for why blood must always be moving forward. If it doesn't, you develop these deep venous thromboses, and right at the spot where the valve is. So remember, when you're relaxed, your muscles are relaxed, those valves are closed, and it's during this period of time when clots form and pieces break off. So that's why it's important, like flights, airlines, the air is very dry. People sit in their seats, and over these very long hauls, they're more at risk for developing a deep venous thrombosis. When the clot breaks off, where would it lodge? Lungs, brain, or intestines? The answer is it's the lungs. And the pathway, clot dislodges from the deep venous thrombosis, goes up the inferior vena cava to the right side of the heart and into the pulmonary vasculature. So the most common sites of clot formation, since if the blood is not constantly moving forward, are going to be in these deep veins, not the superficial veins, but in the deep veins. So varicose veins doesn't increase your risk for a DVT. The other spot is in that left atrial appendage. We went through this in the cardiovascular system, but I'll go through it again, how important it is that a person with a dilated atria, either the right or the left, but generally it's in the left atrial appendage that a clot formation will begin. What component in blood initiates the clot formation? Albumin, platelets, or thrombin. And this is an image, remember, of the bone marrow, cells in the bone marrow coming from hematopoietic stem cells. And they create these three major types of cells: red blood cells, white blood cells, or what? And the answer is platelets. So platelets are these small cells that travel around to ensure that there's no breaks in vessel walls. So when they possibly do see a break in this depiction, they start to surround and they grab on to all the blood, and then they initiate this clot formation. And then thrombin starts to form, and then it begins this clotting cascade. Now, the other interesting thing about platelets is that they can only live 7 to 12 days. So they're constantly being formed. I'm going to come back to that in a minute. Let's go for the medical scenario. You have a big Christmas dinner. Your uncle has type 2 diabetes, hypertension. He's had a heart attack and he's still not changed his lifestyle. You know he has plaque in his coronary arteries. So after dinner, he starts complaining of quote unquote indigestion. He begins to sweat and his face turns ashen gray. Now, people with indigestion, I may say, usually don't progress onto sweating and this ashen gray. That's when you start really worrying about someone having a heart attack. So he takes his nitroglycerin and it doesn't help. What else should you give him while waiting for the rescue squad? Should you give him more nitroglycerin, some wine to calm him down, or give him some aspirin? And the answer is give him some aspirin. Why does this work? Okay, let's go back to the heart now with these plaques. So during the heart attack, at top of one of these plaques ruptures, and then this rough site is picked up by platelets as a spot where it potentially bleeding spot. It's interpreted as a bleeding spot. So it develops complete blockage. That clot grows and it prevents complete blockage. And then the dead heart muscle leads to a disturbance in the cardiac conduction system, which can lead to a fatal arrhythmia. Is usually the mode of death is the fatal arrhythmia. So aspirin is a medication, used as a medication to stop platelets from continuing this clot formation. So platelets block this cascade from resting platelets to activated platelets. And this aspirin will do it for the life of the platelet. So for people that are at risk for having a heart attack, I frequently put these patients on aspirin to keep, they call it to keep the blood thin, which means simply that they keep the platelets from becoming activated platelets. Increases the risk for bleeding as well. So another question, do you know another over-the-counter medication that inhibits platelet formation? Let me give you a couple options. Would it be something like Motrin, Aleve? Would it be Tylenol? Or would it be something like Sudafed? The answer is going to be Motrin. The difference with Motrin is it's gone in 7 days. So it does not hang around for the life of the platelet like aspirin does. So aspirin is a better choice for someone with coronary artery disease. All right, so in summary, we've gone through the blood types, gone through Rh antigens and clotting emergencies. Type O being the greatest in the population, universal donor, most common blood type. Type AB, they're universal recipients. Type A will accept only A or O, and type B accepts only B and O blood. They're very much less common. And of course, AB is the rarest. We've gone through erythroblastosis fetalis and how a mother who is Rh negative can develop antibodies to Rh if she's had exposure. And then again, how aspirin or non-steroidal anti-inflammatory drugs will inhibit platelet function. Aspirin for the life of the platelet, so people, when they're coming for surgery, will be recommended to stop their aspirin for up to 2 weeks. people that are taking non-steroidal anti-inflammatory drugs like Motrin, Aleve, Advil, that stop their medications for just 7 days or so. And other point, never stop moving and always keep your blood pumping forward. Any questions, please leave comments in the comments section. Thank you.